We thank you all for joining us as we revisit the changes to Medicare that occurred as of January 1st. Before we get started, I'd like to go over just a few housekeeping items. And for those of you who are not aware, give you an overview of who we are. Excesia Health is a national nonprofit organization that assists individuals with rare and chronic conditions afford their health care. I am Tiara Green, president of Excesia Health, and glad to be your moderator for today. All lines are muted. And for the convenience of some of those who may be hearing impaired, closed captioning has been turned on. We will be answering any questions that you may have. If you just click on the Q&A section on your screen and enter your questions, we will save time at the end to address those. And again, this is being recorded and will be available on our website. Next up is all of the compliance items, right? Excesia Health webinars, events, conferences are intended to provide information to the public. The views and opinions expressed by any speakers or other third parties are not necessarily those of Excesia Health. And without further ado, I am glad to announce our panelists for today and introduce them. And first up, we have Laura Cave, Chief Brand Officer with Patient. Laura is an early stage marketing leader with a passion for healthcare and track record for driving growth. In her role as Chief Brand Officer for Patient, she is focused on elevating Patient's brand and category to help millions of Americans more easily access and afford care. After years in marketing roles with brands like The Knot and AOL, it's a flashback. Laura found her purpose in healthcare after taking a role with Oscar Health in 2014. From there, she's been involved in early stage growth of K Health, Ansel Health, and now Patient, which she joined in 2022. She holds a Master of Arts from NYU and a Bachelor of Arts from the University of Southern California. Welcome, Laura. We're happy to have you.
Thanks for having me.
Next, we have Melissa Page. Melissa is the president and co-CEO of the National Association of Medication Access and Patient Advocacy and Healthcare Advocate Summit. Melissa's journey spans from hands-on patient education to shaping pharmaceutical market access strategy to leading as the president of a nonprofit, giving her a unique 360-degree perspective on medication access. As president of the National Association of Medication Access and Patient Advocacy, also known as NAMAPA, and co-CEO of Healthcare Advocate Summit, she is fiercely committed to breaking down systemic barriers and ensuring patients receive the life-changing treatments they deserve. Thank you for joining us, Melissa.
Thank you.
Last but not least, William Sorrell. He is president of Sorrell and Associates. Bill is a professor of practice, at the University of Maryland Francis King Carey School of Law. That's a nice long title.
It sure
It
is.
is a nationally recognized, he's a nationally recognized expert in healthcare, the Medicare program, and patient access to drugs, medical devices, and other treatments. The founder of a consulting practice, Sorrell and Associates, Bill is an advisor to Excesia Health and other charities and patient advocacy groups. Bill also serves as general counsel to another patient access organization and is board member to a rare disease advocacy organization. Thanks for joining us, Bill.
Great to be here. Thank you.
And we're going to turn it over to you to kick it off with just a recap of out-of-pocket cap that went into place in January, as well as the Medicare Prescription Payment Plan.
Well, great. So there is good news from the Inflation Reduction Act. If we go to the first substantive slide there, as of the beginning of this year, for the approximately 1.5 million Medicare Part D beneficiaries who in the prior year had out-of-pocket costs that exceeded $2,000, and that obviously is a significant number. They now should be protected against out-of-pocket costs in excess of $2,000 by virtue of the Medicare Part D program now imposing this $2,000 cap. Great news for a lot of people. For a number of beneficiaries, the cap actually is lower than $2,000, depending upon the commitment that your particular Medicare Part D plan may have made to you for your out-of-pocket expenses. If the plan, in fact, made a further commitment, then that is binding on the plan, and you'll experience a cap at an even lower rate. Perhaps the best part of this aspect of the two changes that we'll be talking about today is that it's self-executing. You don't have to do anything. You don't have to file an application or sign up or contact anyone. This cap operates automatically within the Medicare Part D system. So great news there. Now, in the next slide, we'll go to the other change that occurred January 1. And that also provides an avenue for additional assistance for Medicare Part D beneficiaries. This is a mechanism referred to variously as the Medicare Prescription Payment Plan, or M3P, or smoothing. And there's a little bit of confusion just because there are so many different names associated with this new benefit, but it's the same underlying benefit regardless of the name. This one does require an opt-in. It requires you as the beneficiary to take an active step in order to benefit from this particular program enhancement. What it allows you to do is to take whatever your out-of-pocket costs are over the course of the Medicare Part D year, and rather than pay that at the pharmacy counter, to smooth that over a series of monthly payments, potentially, if you opt in early enough in the program, over a 12-month period for the year. So this can be very beneficial if even with the $2,000 cap, you have out-of-pocket costs as part of your Medicare Part D coverage that are difficult for you to meet at the pharmacy counter. If we go to the next slide, that tells us a little bit more about this opt-in requirement that does differentiate this from the $2,000 cap. The M3P program is a voluntary program. It requires you to actually, again, take a step to effectuate your entry into this particular benefit. And that's a little bit of a disappointment to some of us, certainly me. There had been some hopes early on that the Centers for Medicare and Medicaid Services and the Part D plans would work with pharmacies to have a point of service opt-in mechanism at the pharmacy counter. But that, unfortunately, at least in year one, is not an option. So you have to sort of think about this and take steps to make use of this benefit before you show up at the pharmacy counter when you want to hopefully avoid paying at that moment your out-of-pocket costs and instead smooth them over a series of monthly payments. So for those of you that this is right for, and that won't be everyone, we'll talk a little bit more about that, you do have to opt in. There are fortunately multiple ways, as the slide indicates, that you can opt in. You may have already done it as part of the plan enrollment process for this year. There is a paper option that the Part D plans offer. There is a toll-free number option, which for many people I think is the preferred option. And then there is a mechanism by which you can sign up through the plan website And Laura will be talking about how Patient offers yet another very convenient option. So lots of good options to pursue in order to sign up. And you do get a confirmation back from the plan when you've been successful in attempting to opt in. Okay, let's go to the next slide and talk about some helpful hints. Smoothing is definitely going to benefit a number of patients. The sort of working assumption at the Centers of Medicare and Medicaid Services is that if your out-of-pocket costs are $600 or more during the course of the year and you sign up early enough in the year, that all other things being equal, this is a benefit that might, in fact, be an advantage for you. And that's a pretty significant pool of beneficiaries that this might help, because it has been estimated by some that 25% approximately of Medicare Part D beneficiaries last year had out-of-pocket costs that exceeded $600. That's roughly about 13 million people. So a big potential pool of individuals that might be benefited. So if your out-of-pocket costs are likely to be significant, and particularly where those costs are going to be asserted early on this year, the odds are that this benefit can be a real help to you. So some of the issues that people are having early on in the implementation of this new benefit is that they don't understand that, unlike the way the way copayments operate when you're not under this program, when you of course made your payments every time you went to your retail pharmacy counter, for instance. Here, what will happen is that you'll receive a monthly bill. So even if you only fill your prescriptions once every quarter, you'll actually get a monthly bill, and your obligation, of course, will be to pay that bill. Another observation is that your premium obligation, if you have a premium obligation, is separate from this M3P payment obligation. So you, in fact, need to be aware that there are two different items that potentially you need to pay on an ongoing basis. You will get a notice as to how much your monthly payments are expected to be when you sign up. It's important to remember, though, that if you add additional drugs during the course of the year, that will change your monthly payment. So this is a bit of a obligation that can change over time, and you should be aware that that happens. The most important thing, though, I want to emphasize is that some people seem to be getting the wrong message. They really are, unfortunately, hearing that signing up with this program means that they don't have to pay at all, and that's not the case. All that this means, all that this particular program means, is that you're moving from a situation where you have to pay at the time that you get your drugs at the pharmacy counter to now paying in the form of a monthly bill exercise. Okay? All right. So I think with that, we will now move to some polling questions.
Thank you so much for that overview, Bill. And you should see a screen pop up for you, and it's going to ask you, has the cost of your medication ever caused you to delay or skip filling a prescription medication? We're seeing those answers come in. All right. We're going to lock it in 5, 4, 3, 2, 1. And you should be able to see these results on your screen with 70% of individuals who are on this call having to delay or skip a medication due to costs. Not necessarily what anyone, I'm sure, hopes for or wants to happen. We did a little survey in our community, and we wanted to better understand how they are navigating the healthcare landscape with the changes that Bill just covered. And what we found was that 33% of patients and caregivers who responded to this survey in 2024, they had a medical expense of over $2,000. And of those 33%, total, 82% are not enrolled in a Medicare prescription payment plan. So, of those with costs over $2,000, only 82, well, we'll say only, let's flip it around, 18% are enrolled in a Medicare prescription payment plan. And if we look at that further, let's take out those respondents who have a rare or chronic health condition. 96% of those, 90% are enrolled in Part D coverage, but only 23% of those are signed up for Medicare prescription payment plan. So I'm going to leave this here in case any of our panelists want to comment on these results, or Bill, I know you may have some thoughts on these.
Yeah, the first slide is troubling. Obviously, that small a percentage with folks who at least last year had more than $2,000 in out-of-pocket costs. Sounds like there may be, a fairly significant education shortfall here, given some of the efforts by the Centers for Medicare and Medicaid Services, and that is concerning. This slide might be a little more positive. As I mentioned, some estimates last year said that people who had $600 or more in out-of-pocket costs accounted for roughly 25% of the Medicare Part D population. And so this percentage looks pretty close to that percentage. But I think the reality of this survey, given the population that you can reach in this survey, is that it's not a reflection of the Medicare Part D population sort of average. It's in fact very heavily weighted towards people who have significantly higher out-of-pocket costs than the average Medicare Part D beneficiary. So unfortunately, I think that the first slide probably tells us more accurately about how the program is being accessed or not accessed than the second slide.
I would
Thank you,
agree
Bill.
with that. And just to build on what Bill is saying, certainly anybody who has more than $2,000 in annual out-of-pocket expense would benefit from this program. CMS identified that anyone with a $600 expense from a single prescription would really benefit from the program, and they're required to receive notification at the pharmacy when those out-of-pocket costs at that $600 level or higher are happening. And however, CMS also indicated that anybody who has an affordability problem at any dollar amount may benefit from this program. And unfortunately, the communication mechanisms at the pharmacy are not there. There's this education gap, as Bill mentioned. And so the fact that people with this high of an expense are not accessing the program, certainly people who are having affordability challenges at lower dollar amounts are hearing about it even less than these folks. I think we can see that there's a pretty big gap here in the number of people that would really benefit from the program. They're not yet accessing the program, and it's because of this awareness and education work that we need to do together as an industry.
Yeah, and I'll add on to all of that. I think the population that can most likely benefit from this, the low income, chronically ill, they also have low health literacy. So we are walking step by step with them. And unfortunately, they're really frustrated when they go to the pharmacy window, and that frontline staff there is getting the brunt of it. And so I think we're trying to pin down of where this education needs to happen, and it's upstream, downstream. And for me, and the 200 centers of excellence and all these thousands of healthcare workers we have behind our organization, that we still have questions on this. And, who should enroll? What if I have a grant, which, we'll end up kind of drilling in there. So, and I'll just say overall, just my number one thing is the biggest confusion is you've got another item under Medicare called a plan, and it's not a plan, it's an option. So there's that confusion of like, I'm already paying for a plan. And so, I would like to see it be called Medicare Payment Prescription Option. So that's been, some key things on when I look at these survey results.
Good observation. I think all the way around, it would be remiss if we didn't mention that this is based on a low sample size, right? So as we look at extending this survey further, I'm interested in knowing how more individuals are reacting to not only the $2,000 out-of-pocket limit and as well as M3P. And I like that suggestion, Melissa. Can we take the plan out? Because many people will say, well, I'm already paying my Part D plan, paying that premium. Is that included in the $2,000? How does that work? One of the other statistics that came out of this was 71% of those enrolled in the payment plan somewhat or strongly agree that they have a clear understanding of their monthly payments. And this goes to that comment that you had about education, right? Making sure that they understand what they're signing up for. And then 52% of those that completed this survey do not remember or recall receiving anything about the Medicare Prescription Payment Plan from their Medicare Part D sponsor. So again, a long way to go, and definitely some education that is needed. And I'm going to kick this over to Laura so that she can tell us what patient is seeing.
Yeah, absolutely. So, patient has the privilege of providing technology that powers the Medicare Prescription Payment Plan program behind the scenes for two of the nation's largest pharmacy benefit managers and dozens of Part D plan sponsors. So we have a unique window into the behind the scenes operations of the program. And so I wanted to bring a few insights, both from what we see in our day-to-day as a technology provider, and also just what we're hearing around the market, because we've undertaken an effort that we're calling Get My Meds, that I'll tell you about in a moment, that is designed to help bridge those education and awareness gaps and create tools that patients and their advocates can use together to better understand what costs may look like under the program and to facilitate an easier opt-in experience. So just some high-level observations from the first couple of months of the program. At a high level, I'm going to echo a lot of what the sentiments that we're seeing in Accessia's survey. The first few months of M3P demonstrate a misunderstood program with a lack of awareness along multiple levels of the member journey. So there are a few different things going on here, and a few key stats I wanted to share that really illustrate this. We do see that the average M3P claim size is below $200 and trending down. This is for two primary reasons. One is because the program helps anyone with an affordability challenge, even if their expense was lower than $600 for their prescription. We know that often Americans struggle to afford unexpected expenses in the multiple hundreds of dollars, and certainly older adults and those with disabilities are even more constrained financially. So I believe that people are accessing the program below that $600 likely to benefit level when they have the privilege of hearing about it and understanding it. The second reason why this average claim size is so low is because when you opt into the program, you're opting to be billed by your plan for all of your out-of-pocket spending for your prescriptions. I know this has been a big point of confusion, and a lot of folks wish that they could smooth the cost of their expensive drug and then pay their day-to-day medications monthly. But it's sort of an all or nothing with this program. So when you're enrolled, instead of paying for your prescriptions at the pharmacy, you'll receive a monthly bill with all of those costs combined and smoothed out over the plan year. If for any reason you'd like to continue paying your monthly bills the way that you have been so that you stay on top of those expenses and they don't stack up towards the end of the year, you're more than welcome to pay more than the minimum amount that's being billed to you so that you're getting the benefit of smoothing out your high cost drug, but you're staying on top of those expenses, understanding they are still your responsibility, and the timing of those payments ultimately is up to you, as long as you're paying at least that minimum payment due that's being billed. Two other quick points that really just demonstrate some of the friction that exists out in the market. And I mentioned these just so that patients and their advocates especially can be aware and can advocate for themselves in this sort of temporary phase while the program is still, the whole market is still learning this program. We heard from a large broker that's in our community, that their average time on a three-way call with a plan to help someone sign up for M3P was 90 minutes. I know others are having a much faster experience than that, but it all depends on the plan and whether or not they require a login to opt in online, whether or not their phone systems are responsive and understanding how to answer those questions and how to get you quickly opted in. And so we're hopeful that this continues to trend down, but be aware that we're hearing that there's a lot of friction, and we built our Get My Meds solution because in part of this kind of feedback coming from the market. And then lastly, we are hearing that at some retail chains, some of these claims are not being processed properly. So some folks have opted into M3P. They should be getting a $0 copay amount after everything has been properly adjudicated. However, if the pharmacist does not file a secondary claim specifically with M3P information in it, then it will just bill through as it typically would, as if you were not opted in. And so I will just say, if you have opted into M3P and you're expecting to pay $0 at the pharmacy, you will want to make sure that you advocate for yourself and you make that clear to your pharmacist, because there are still some pharmacies that are not able to view the M3P status codes in their system, and they've got some clunkiness in their operations. And so I just want to warn everybody that you might need to be a little bit more of an advocate for yourself in those moments, because the pharmacies are still figuring out how to work with this program. All right. So at a high level, we are hearing that beneficiaries really like the M3P program, but they're not enough of them are aware of it, and they're struggling to opt in. The likely to benefit threshold that we spoke about earlier, which is that $600 when the pharmacist is required to give a notice of likely to benefit, that's going to exclude a lot of people who struggle to pay smaller amounts. And who are we to say, what's affordable or what's not to a beneficiary? And everybody has the opportunity to participate in this if they would like to. So I just want to make sure I'm loud and clear that the $600 likely to benefit amount is not an eligibility requirement to participate in the program. Everybody is eligible to participate in this option if they have Part D coverage of any kind. And then we've already spoken ad nauseum about the education gap. And unfortunately, there's no one source of truth explaining the entire M3P life cycle. So on this next slide, I want to show you sort of what the member journey looks like and where some opportunities might exist for us to begin to change how this feels. And so if there's anyone on the call who, is from a provider, is involved in the pharmacy delivery system, these are the things that we're looking at to make the beneficiary's journey better. So first and foremost, when a drug is prescribed or renewed by a provider, we're looking at opportunities to provide education about M3P through the provider's office. Often providers are assisting with step therapy, prior authorizations, other types of manufacturer support programs in order to ensure that the patient can actually begin therapy and stay on therapy. So where those workflows exist, we're exploring ways that M3P evaluation could be added to those workflows so that the provider's office can continue to be that guide for helping people get on a prescription drug therapy. Then as communications are going out about the steps of that process, whether there's step therapy involved, prior authorization, et cetera, there may be moments to communicate along the path there. And then when the pharmacy is preparing the drug and is notifying that the drug is available for pickup, that could be another moment when M3P could be highlighted where it's relevant, where there's a high out-of-pocket cost. And then lastly, when the patient arrives at the pharmacy, they should learn about it at that point. Certainly, if they're designated as the message code is 056 likely to benefit, and that's triggered when you have that single prescription cost of $600 or more. Our tool that we've built that I'll share in a moment can be used on a mobile phone or a tablet device in the pharmacy setting. However, the plans today have 24 hours to process an opt-in request after they receive that from you. So even if you opt in over the phone, they're going to have to do some things in the back end. Some plans are faster than others, depending on how often their data syncs with the PBM and through to the pharmacy systems. So I did see this in a comment in our threads earlier. The real-time opt-in was intended to be a requirement, I believe, for 2026. And so we're still waiting to hear, what CMS will officially require of the industry for that. But we are actively working to make that as seamless as possible because we know starting therapy in a timely manner can be really important. In some cases, those hours and days really make a difference. And so that's one of the reasons why not only are we concerned about that moment at the pharmacy, we're also looking upstream in the patient's journey so that they can be preparing for this in advance. Kind of like Bill said, you got to think about it in advance, take that action early when you're enrolling and in the program and electing that option. And then by the time you arrive at the pharmacy, they have that information and are able to adjudicate your claim appropriately the first time. So with that, I want to talk to you about Get My Meds, and then we'll pause and have some more discussion. So seeing that there were no tools in the marketplace to assist beneficiaries with understanding the M3P program, understanding what it would mean for their personal financial situation, and then lastly, facilitating a fast and easy way to opt in, we decided to build tools that would do this. So if you visit getmymeds.com, is a completely free service. It is secure and HIPAA compliant. It passed all of our rigorous security and compliance reviews from our team. And you'll find their program education, answers to frequently asked questions, informational videos, and then two tools that I think I mentioned earlier. The one you're seeing here on the screenshot is the cost calculator. So if you put in the amounts that you will be charged out of pocket in the months of the year and then hit calculate, it will show you what the statements would be, the value of those statements that would be billed to you so that you can anticipate, okay, would I be able to pay these monthly statements? And then the last piece, which is actually the opt-in now button at the top of the screen, there is no other button on the internet that allows you to opt in to send an opt-in request to your Part D plan to participate in the M3P program besides this one. And what we did is we pulled all the public information from every single Part D plan, not just our clients, anybody in the market, no matter how you get your prescription drug coverage, whether that's a Medicare Advantage plan with prescription drug coverage, a Part D plan, everybody's represented there. You're able to select your plan and fill out their opt-in form because all the plans have different opt-in forms with different terms and conditions. So we got the correct ones for you. You fill in that information and you're able to e-sign it very simply there on the website and submit that to your plan. We send that securely through either a secure electronic means or secure mail, depending on the most expeditious channel that's available. We try to get that to them as quickly as possible. And then the plan is required to process that within 24 hours and follow up with you to confirm that you are opted in to M3P. So that is what we have built. It's available for consumers, for anybody can use it. People are opting in to M3P through this tool every day. We are now working to distribute this tool so that it can be present in those workflows that I spoke about at the provider's office, at the pharmacy. And so that's like easier and in workflow for providers and pharmacies who are already working to support patients. So I think I'll pause there for some more discussion.
Thank you so much for that overview, Laura. And I'm excited so that we can get into more discussion. And I want to keep that going with your overview of how individuals could opt in. What are some steps that Part D plans are taking to ensure that enrollees are informed about the payment plan option?
Sure. So Part D plans have a list of requirements from CMS about how they need to inform their members about the program. So they have been putting information on their websites, on their in their regular mailings. So their annual notice of coverage, their explanation of benefits are all supposed to have information. And then anybody who spent more than $2,000 out of pocket, like that 1.5 million that Bill mentioned earlier, they were supposed to get a likely to benefit notice specifically for them because their spend was higher than the cap last year. And so to my knowledge, all of that has been done. However, it may not have been done in a way that was extremely easy to understand. I think that, the plans had a lot to do to become compliant in a very short time window. And there are a lot of unknowns for the plans about this program. And so many of them opted to do just exactly what CMS asked and no more. And so I think as plans understand the program better, we're starting to have conversations about how this can intersect with some of the efforts they're making around STAR measures and things that are, connected to access, affordability, and overall wellness, and outcomes. But I think they're just in a tough spot with promoting information about the program. And so, and likewise, pharmacies have had a lot to do to change their own operational processes, and they were not directly impacted by the guidance that CMS provided. So they were sort of late on the ball getting going there, and they've needed some time. And plans have been working very aggressively and directly urgently with their network partners to make sure the pharmacies are closing those gaps and cleaning up those operational problems, because we should not be seeing any of that. And so I was really pleased to see that there's a lot of activity happening right now to make sure that people who are opted in are getting the experience that they should be getting at the pharmacy.
That's great, and glad to have the tool around that patient created so that it makes it a little easier for those who are interested in signing up.
Yeah.
You all are well involved and engulfed in the patient assistance arena, and you're interacting with policymakers or patient advocacy groups or pharmacists or patients themselves who are people, right? Now that M3P and the Part D cap is in place, just tell us what you're seeing. If each of you, from your different perspectives and expertise, can tell us what you're seeing in the industry.
Go ahead, Bill,
No,
you
no,
kick it off.
no, you go ahead. You go ahead.
So what I'm seeing, right, from the ground level, which I love hearing, yes, everybody can opt in. Yes, this may be an option for people who can't afford their meds, regardless of the cost. Where I sit at, and I'm still skeptical of a lot of the things on here because I want to make sure that I do not put my patient in a position that maybe they would have been better off on another route, if a grant came up, which that's a discussion I still have, Tiara, and we've had multiple calls on this
Yeah.
that I think right now the biggest thing that I'm hearing is should every patient enroll regardless of the threshold? And from what I'm reading and some great articles on Forbes and just like actually seeing that calculation as well, that we're really taking in account of, okay, this is going to be another pathway that they have to pay. Can I find foundation assistance? Will foundation assistance be open, shortly? And trying to make sure that if I enroll in smoothing at the beginning of the year, find a grant in March, is that going to make them ineligible for, helping out on this, what that looks like? And I think overall of enrolling the patient, right? Like normally we help guide, which Laura, your tool is really great. And it sounds like either on the back end, those who you're connected with, you can automatically kind of go that route. For those that are not, it's a redirect, at least to the right place, because it's really hard to find where that is on the website. So I love that tool. But for us and what I'm facing, and I'm like the secret shopper going around to every retail pharmacy saying, hey, tell me about M3P. And nobody has a clue. Or I'm asking what they do and how they educate and trying to just explain I'm a patient. And so I think there's a huge initiative, and I hope I hear more from this of we deal with a lot of specialty pharmacies, right? From the chains who also have retail locations. I would like to kind of see what they're coming out with as an education or kind of those different steps, or maybe connect with some retail pharmacy techs as well. But for me, the biggest thing that we're seeing is how do we make sure that this patient, this is the best option for them. They have received a lot of communication, but just like I tell my grandma, throw it in a pile and I'll see you in a month. So that's a concern, right? That bills are coming and they're not paying them, they'll get unenrolled. So it's just a lot of confusion, and it shouldn't be confusing for me who's advocating for the patient, that I have found every loophole, checkbox, the pathways. This is just something else added in to patient assistance programs, foundation,
Sure.
copay, and, accumulators, maximizers, AFPs, everything else. So this is just one additional little 3-letter acronym that we're dealing with. And I think everybody's kind of handling it in a certain way, and we're all just trying to find answers.
And find answers for the people that depend on us, right? I do want to answer that question on how individuals are able to handle their claims when they are receiving assistance from a patient assistance organization. Of course, I can't answer for all of our peers in the industry, but I can answer from an Accessia Health perspective in that we do assist individuals if they have a Medicare prescription plan. However, the date of service has to fall within their eligibility dates, meaning, let's say they just signed up March 1, but they filled a prescription in January. and they're making monthly payments on that January fill. Because it was prior to their eligibility date, we may not be able to assist. However, if they received patient assistance that began March 1st and they had a fill in, let's say today, the 27th, our hope would be that the pharmacy is running it according to the hundreds of pages of CMS documentation that says run their insurance first. After you run their insurance, you run the claim with the PCN and BIN number provided from Accessia Health so that we pay all of their costs before it gets billed to the Medicare prescription plan. It doesn't have to go through them. However, if it does, we will make that payment directly to the Medicare Part D sponsor so that they're not worried about the claim amount every month.
So Tiara, I'm going to throw this out there, and we don't have to answer this now, but just what you mentioned is if I enrolled my patient in January, they had that claim. I don't know what everybody's backdate services are for foundation.
Yeah.
That if something in April comes up and I'm so excited this is going to help out, maybe I can get a final bill. That's not how it works, is what it's sounding like. That if you see that claim in January or like where it was initiated from, they may not be eligible for that foundation assistance on there. Do you see, or maybe this is something that the foundations, once we start seeing these come through, like the rules on backdating and some of these things too, like, is that something, the thing that kind of pops up on my mind, because the date of smoothing is not the date of the claim, or all these things that
Sure.
just for me, and I know we've got 100, 500 people on the line. I'm just trying to work that in my head on there.
Yes. Yeah, and it's a good question. It's a lot to keep up with everyone's backdating policies and how their assistance works. Ours goes back to the first of the month in which they applied, right? So as long as they're eligible, it goes to the first of that month. But there are some foundations who go to the first of the year. We'll have to all put our heads together to help those that we serve navigate and not have to search every site for that information. But Bill and Laura, what are you seeing?
Yeah, well, I play secret shopper too. I have gone to a number of pharmacies, and I am sorry to report that the answers I get back from folks at the counter suggest to me that there's a real problem in education. I've actually on several occasions seen the disconnect. I've seen people, present at a pharmacy counter, shake their head and say, "I can't pay that," and there's no discussion about M3P. I find myself jumping into conversations and pointing out that there may be a resolution of this problem, and here's the option. But I, of course, am not at the pharmacy counter nearly enough to deal with all of the issues. I do want to say that for some people, there may be an option that's even better than M3P. That is, of course, the low income subsidy, the LIS or extra help option. So if you have monthly income of $1,975 or less and you meet certain restrictions on assets, or alternatively, if you already are a recipient of Supplemental Security Insurance, SSI, from the Social Security Administration, you qualify under that program for zero premiums, zero deductibles for Medicare Part D, and then very low copayments in Medicare Part D. The highest copayment obligations you can have under that program, highest, it could be lower, is $4.90 for a generic drug, each generic drug, not generic drugs, not all of your generic drugs, but each individual generic drug. And then the highest that you can be charged on each brand name drug is $12.15. So I think that the other thing I've seen sometimes in my secret shopper efforts is that there are pharmacies that do jump to a discussion of M3P, but they don't ask first about whether the patient would qualify for extra help, which
Mm.
for some people is going to be even better than M3P.
Sure, sure. This is a really important discussion. I'll just add, we have done a phone survey of about 300 pharmacies in Missouri. That's where we're headquartered, and we wanted to get a pulse on this as well, sort of in a secret shopper kind of way. So we called them and said, tell us about M3P. Are you working with that program? How does it work, et cetera. And about 25% of the pharmacies we called were negative or confused about the program. Another 45% were neutral. They only speak about the program if asked or if required by that 056 likely to benefit notice that needs to be delivered, which happens very rarely in retail pharmacies. And I think because it happens so rarely, the pharmacies are not getting the practice that you would get maybe perhaps in a specialty pharmacy setting. So it's taking them a while to get used to the different operational processes that they have to go through. And then there were about 30% of pharmacies that we spoke to who said they were educating at $100 or $200 out of pocket. They were being proactive. They felt they could confidently explain the program and answer questions about it. So that was a positive signal. And we're hoping that that group grows as they get more experience with the program. But I think, this discussion is really important because what we're saying is, and some of our clients have taken this approach as well, you should always try to lower your cost before you smooth your cost. And it's never an M3P or foundation dollars or LIS. M3P can be applied across any of that. So, my personal opinion, and it's only that, is that everybody would benefit from signing up for M3P, even if you lower your costs with LIS and you have $5 copays. If you have 4 drugs or 5 drugs, and that $25 is a choice between dinner for your family or getting your medications on time, you're skipping those medications. And many people live in that reality. And being able to settle that at the end of a month, we heard that over and over again in our focus groups. Gosh, if I could just get my meds on the day I need my meds and pay the bill at the end of the month, I would do that. That would be so much easier for me. And it really just speaks to a point that we have to emphasize a lot here at Patient, because our whole business is smoothing costs over time as an affordability tool. And even when you don't change what the cost is, the option to pay a little at a time dramatically increases affordability, confidence in actually seeking the medication or the service, and ability to pay. That confidence makes a really big difference in adherence. And we hear over and over again, I'm getting access to medications and medical services that I had been putting off because now I have the option to pay slowly. And so, yeah, just always lowering our costs, but then always spreading our costs if we can. It's going to increase that affordability aspect. And that's just kind of our point of view of why we think M3P is so important.
Can I
I totally get that point of view, and I think for a lot of people, that's the right answer. I do think, in the grand scheme of things, this $600 likely to benefit figure sort of set us up to underperform in signing up patients. So totally agree with the thrust you just said. I do think, though, there are patients out there for whom smoothing is not a great option if they have, because perhaps they're getting extra help, very low copays, and they can pay those low copays at the pharmacy counter with the assistance of that pharmacy tech in that exchange. Um, Unfortunately, there are lots of folks in the Medicare population that are operating with capacity issues, that have dementia or other problems. And so in those sort of context, monthly bills can get lost in the shuffle. So
Yeah.
there are exceptions to every rule. And I can think of some circumstances where, smoothing might not be the right option, but I do absolutely think that the way that this program was framed in the first instance sort of undersold the value of the benefit to lots of people.
Yeah.
Yeah, and I just, Laura, with your survey or just what you've been hearing, right? Because you see a lot of claims and these things, as the patient signs up or goes back to the pharmacy, you've got this 056, 057. Have you seen anything on the back end, like from a pharmacy tech, seeing that back screen? I'm going to have to know where to find it. It's probably popping up where everything else is, but anything that you can tell us on that? Because I've had my patients go back to the pharmacy and they're like, sorry, we don't see anything, when we just went through this whole process, an hour and a half on the phone. How do we help our patients? Like, what have you heard of anything on the back end of what's happening at the pharmacy?
I do know that the plans are working with the pharmacies to ensure that where, an opted in M3P participant was charged a full amount rather than because they failed to file the secondary claim. That is a very real thing that was happening in as many as 20 to 30% of instances. That I'm understanding has been brought down, at least in one major chain, down to a gap of only 10%. So they're working very quickly to close that down, and to correct that. So there is the support of the PBM and the plan pushing on the pharmacy to get this right and to make sure that those things are visible. We're also speaking to PMS vendors, the pharmacy management systems, who provide the technology on those screens to ensure that M3P has enough real estate, both for education and for seeing just those codes. So we're engaged with some of the pharmacy trade organizations. We're doing a webinar next month on April 8th with NCPDP that will involve the plans, the PBMs, the pharmacy supply chain vendors. We're also hearing from the drug manufacturers and their patient assistance programs. They're engaged in this as well, and they're very interested in supporting M3P opt-in in conjunction with patient assistance. And so, again, wherever, Get My Meds and an easy opt-in flow with the support of an advocate could make a difference. We're trying to make sure that we're showing up in those spots to ease those points of friction. But hopefully that answers your question.
Yeah, I know it does, because I know sometimes those messages are truncated or they look weird, or, for me in education. And you brought something up just because you brought patient assistance. So what I'm seeing also on the ground, and I just went to another event that stated this, there are patient assistance applications, right? The free drug programs say nothing is available, foundation assistance, that actually one of the requirements is to enroll in smoothing before you can be eligible for the program.
Yeah.
And so my question back, and Bill, maybe you can answer this. In my mind, I'm like, all right, I understand we need to exhaust every effort, but I already know my patient can't afford $166, 60, whatever the change is. And so now me as a healthcare worker, I'm like, all right, I'm going to help my patient enroll in this. And maybe it helps them out later on, but just to tell the patient assistance plan, yep, I did it. And then now I'm back to this because that was their only $2,000, drug that they had. And maybe they can afford, Bill, the monthly payments or stuff. So my mind, I'm like, okay, unenroll, enroll. And I'm hearing kind of these different things. But Bill, that's just something I found out like 2 weeks ago, that this is now how patient assistance programs are running too.
Yeah. I think that is not uncommon. And there were, some manufacturers that were signaling that that was going to be their enrollment application requirement in the fourth quarter of last year. They were already, sort of signaling that, and others I don't think were perhaps as public as quickly with that. And so it doesn't surprise me that you're sort of encountering that now as the year begins. Yeah, and I get the frustration, so many hoops to jump through. I would say from the Patient Assistance Foundation perspective, they unfortunately are under assault for a variety of issues that relate to things that you quickly mentioned earlier. The accumulator, the maximizer, the alternative funding benefit programs are really in a dramatic way sapping the resources of those foundations. And so they are, for that reason, changing their procedures in a way that does, in fact, impose more on applicants in order to get to that support. And that is unfortunate, but I think it is inevitable in the environment that we find ourselves in. So I'm so sorry to hear that that's in fact the burden that it is on the patient advocate side. It pains me to hear that, but I see the lawsuits and a lot of the other activity around those patient assistance funds, and the difficulty that lots of, from my perspective, bad actors out there are taking advantage of that source of support. And unfortunately, those patient assistance programs are responding to those threats.
Thank you, Bill.
It's very difficult to navigate, not only from a patient perspective, right, but from a patient assistance organization perspective, with many individuals coming to us and needing the assistance. I absolutely hate that we are out of time because there are a lot of good questions here. We are going to type up responses to the questions that we've received here. So we will share that in the recap email. I want to thank Bill, Melissa, and Laura for your time today. It has been great to talk to you all, and we are grateful for the expertise that you've shared. We probably need to extend this a little more, even if it's just a little podcast for us to get some of these questions answered. We do appreciate your time again. Thank you all for joining. There is a survey at the end of this. We hope that you will take the time to answer those questions so that we may continue to provide the education that is needed for all of those who jointly we are serving. Again, thank you for your time, and we will send this out soon.
Thanks so much.
Thank you.
Thanks,
Thanks, guys.
everybody.